Good afternoon, friends. Welcome to the 10th webinar of Centre of Metabolic Surgery, Mumbai. This concept of webinar started after COVID came in and has become quite successful because now we have access directly to in your clinics. We are able to provide information. And even more than that, we have access to those rare specialties who are or specialists who are so busy in their practice that it's difficult to get their appointment and difficult to invite them for a talk in a conference or a CME. But here the advantage is that these specialists, they are available and they are able to spread the information all over the country. Earlier, when we'll have a CME, it will be in one part of Mumbai and only nearby people will benefit. So today we have a very interesting topic, probably the most important topic in obesity management, a topic which is so close to my heart, the childhood obesity. And why this is so close to my heart is because I have seen its growth the last 20 years. I have been practicing obesity and I have seen the numbers increasing of obesity in children. And I'm really scared of this particular problem because this problem is one which will be affecting our country and the world in much bigger way than what COVID is affecting. Because this problem is going to affect lifespan of people. This is already causing early deaths in our country and is having major problems. So this is a epidemic already, and it has a potential to turn into pandemic. And one expert from Australia who did a lot of studies, and we called him for an international obesity conference in 2009, and he said that this is first time in human history that the children are likely to live shorter than their parents. And the main reason for that is childhood obesity. So friends, today we start our academic session with first speaker. He's a pediatric endocrinologist, and Dr. Prashant Patil, who is a practicing pediatric endocrinologist at Jaslok Hospital, SRCC Hospital, Mumbai, Haji Ali, Apollo Hospital, and Zain Hospital, Chembur. Now, pediatric endocrinologists are very few. I mean, like in Mumbai, we will have, I think, 2 full-time and 1 visiting pediatric endocrinologist to the whole city. And the reason that Prashant told me just before we started talking to you was that there are very few training centers across the country. And that is why it's so difficult to get their appointments, because the number of obese children is increasing rapidly. And so Dr. Prashant Patil is going to talk about childhood obesity. And after that, we have a pediatric nutritionist, which is again a more rarer breed of specialist, who is going to talk today, Ms. Priya Karkare. And then I'll be talking briefly about how bariatric surgery helps in treating childhood obesity in the extreme cases. So Dr. Prashant, please go ahead.
Very good afternoon to one and all. Sir, can you see my presentation?
Yes, very well.
Okay. So at the outset, I'd like to thank Goel sir for inviting me for this much awaited topic in the recent. So in next 25 to 30 minutes, I'll be dealing with what is the obesity, when exactly one should call a child an obese child or an overweight child. There are a lot of numbers which will come in. I'll try to simplify as much as I can for the practicing physicians. So to begin with, obesity is nothing but the excessive storage of energy. So whenever you have more input in terms of food or energy, it gets converted into fat as compared to the lean body mass. So whenever there is an imbalance between that input and output, it gets stored as a form of fat, and which is what we known as obesity. Now, as Sir rightly pointed out, it has already reached to a epidemic proportion. Initially, it was considered to be a disease of reach or Western world, but not anymore. It is seen everywhere. In fact, the WHO report, which came in 2016, in that it has stated categorically that it has reached up to 41 million in under 5 year, and they have claimed that they are overweight, and out of one third of that population is actually obese. Although we don't have a nationwide specific survey or the disease specific survey, but there are various data coming from the south and one from the north. It has reached the prevalence of around 16% to 19%. That is the data which was published in 2016. And one interesting study was done from the major metropolitan cities like Kolkata, Mumbai, and I think south in Madras. They have seen that one third of urban population of school going children are overweight. So, irrespective of their economic data, so that's worrisome. So again, in India, it's not like that only the rich or the affluent will get obesity, but the obesity is seen in across all strata of life. So it is there in the poor and it is there in the rich, and it has reached up to epidemic proportion. And why one need to worry? Because if the trend continues, and this is the paper which has been published in pediatric obesity, that they are predicting almost 268 million children between 5 to 17 years to be overweight, and almost 1 crore will be obese by that case. Now, what it ultimately lead that we have to live with the morbidity related to obesity. That could be a type 2, it could be an impaired glucose tolerance, hypertension, sleep related problem, or hepatic steatosis. So time has come that we have to prevent this obesity at first, and we have to address this issue. And first we have to identify that which is the population that is exactly amenable to treatment, rather than just looking at the tip of the iceberg. Now, I'm going to show a pediatric cutoff for the obesity. Now, these are the new IAP growth chart, which has been published in 2050 by Dr. Vaman Khadilkar sir. And this on the flip side, you have a height and weight, and on the back side, you have body mass index. Now, just to draw your attention, this graph has the percentile line, that's the black line, that's the third line to 50th line. That is what a normal percentile chart for the BMI from 5 to 18. Now, whenever your BMI is more than 23rd adult equivalent, that is this orange line, then you qualifies for the overweight. And whenever your body mass index is more than 27th adult equivalent, it is obese. So it's not 25 or 30, which we generally see in adult definition of obesity, but it is the adult equivalent of 23 and 27 for the Indian children. Now, why Indians have a much lower cutoff as compared to 25 or 30, which we commonly use in adult population, I'll come to that. Now, whenever we want to calculate the BMI, we know the formula. There are calculators available for it on your smartphone. You just have to calculate the weight and height, and weight in kg and height in meters, not in centimeters, but in meters, and square of it. So you can plot that BMI on this growth chart, and I can assure you that you will see more and more number of obese or overweight children, because these cutoff, mind you, they are much lower. So that means we are almost neglecting obesity, and we can unless and until we plot them on the growth chart, we generally normalize the obesity. We just consider that it to be healthy. So unless and until we plot them on the growth chart, we may not be able to know that the particular child is overweight or obese. Now, if it is too difficult for you to plot them on the growth chart, you have the IAP growth chart available on your Play Store or a Google Store, which is free of cost. Again, it is based on the same data of IAP 2015, where you just have to select the gender, their age, and enter their weight and height. It will calculate the BMI, and most importantly, it tells you the interference. So just to show you an example, this is a 7.5-year-old girl, and we have put the weight and height. The weight is 32 and her height is 122 centimeters. So we have selected the gender, we have put her weight and height and her age. So her age is 89. Once we click on IAP for BMI for age, this is what the chart looks like. So as you can see, this is the point and which is way above the 27th adult equivalent. So this red line is a 27th adult equivalent, whereas this yellow line is a 23rd adult equivalent. So here you can see the inference that BMI is above the obese percentile. So patient is obese. So this is importance of diagnosing them at much early. So most of the recent papers, they say that if you intervene at much earlier age group, the outcome is much better as compared when they reach into the adolescent or teenage group. The treatment is extremely difficult, often frustrating, and they often doesn't stay or stick to the guidelines or the treatment manual that you would apply. So it is important in terms of preventive management. So whenever your point is between yellow line or the orange line or red line, that means in the overweight zone, they are amenable to a simple lifestyle modification, and it can do a wonders by just by doing physical exercise and selecting a good diet can prevent them getting into the obesity. Now mind you, whenever we are seeing the obesity patients, obviously since last 2 or 3 years it has definitely reached almost 50%, that that's the number of patients that we see an OPD. But also what we see classically, that when the patient comes to us, their BMI is way above 30 or 32. So that means we are just seeing tip of the iceberg. Majority of the population which is overweight or just about overweight, they never come to us, probably because they have never been charted, or they do not know how to plot them on this particular growth chart. So my request for the physicians or the pediatricians who are listening to this, that whenever you are seeing a child who is more than 5 year old, please plot them on the growth chart, or if not possible, at least take their weight and height and use the application which gives you the automated interference as well. Now, when we see the etiology of the obesity, your 90% of the cases of obesity is your polygenic or nutritional or simple obesity. That means just the imbalance between the input and the output. And this is where we are struggling, because we have reached to a sedentary lifestyle. Everything is on tip of your fingers. So there is a lack of physical exercise. As opposed to that, the diet has much more carbohydrate and it's much more fatty. So that's the nutritional obesity which comes to you, where the child is absolutely fine. They don't have any other symptoms apart from funny looking physical feature, but otherwise they are okay. Now, less common type of obesity, which is endocrine related, or the endocrine etiology, is seen maybe in 5 to 7% of the cases, where most common endocrine system involved is thyroid. So hypothyroidism, similarly, the Cushing disease, that is adrenal cortex hormone excess, or pseudo hypoparathyroidism, are rare causes of obesity. Now, hypothyroidism as such, when it is associated with juvenile hypothyroidism, it does associated with some sort of weight gain. But most of the time, whenever we are seeing a child, they generally come, those who are obese, they generally come with the TSH report, which is just borderline high. So here I want to stress out that whenever you are seeing a obese child, whenever his values of T4 is absolutely normal, but there is just marginal increment of TSH, that doesn't mean that it's a hypothyroidism. And you should not start them on a thyroxine or a thyronorm, because it is a secondary thyroid hormone resistance due to the effect of leptin. So if it is overt hypothyroidism, you will definitely see a low T4 and very high TSH. A marginal TSH increment is extremely common in your nutritional obesity, and you should not treat them, or in fact, you should not ask for the thyroid hormone test at first place. Similarly, there are some hypothalamic or pituitary gland involvement can also lead to obesity, like Prader-Willi syndrome. Some of the syndromes are having obesity as their predominant manifestation. One of them is Prader-Willi, Cohen, and other symptoms which has a special sense affection. Some of the genes which is controlling the energy input and output, like leptin or the POMC or MC4R, which is commonly associated, any mutation in those genes is associated with a dangerous obesity known as monogenic obesity. But having said that, this obesity percentage is maybe less than 1%. So we have to have definite pointers towards a monogenic obesity, and we with the help of genetics, we can certainly prove this particular diagnosis. Similarly, hypothalamic obesity is very difficult to treat, and it is associated with extreme polyphagia. There are symptoms related to it. On MRI, you will see the changes related to a hypothalamic pituitary axis. And rather than that, more common in our setup is a drug-induced obesity, sometimes excessive dose of the steroid is associated with temporary weight gain and moon-like faces, which all of you are aware. Maybe a case of nephrotic syndrome who is on high dose of steroid during early phase, and if it is not getting taper, that is the drug-induced obesity which we commonly see. Now, I'm going to show you the growth chart. This is the front side of the growth chart, and I'm going to show two examples. And just to give you an idea how just plotting on the growth chart help us to reach the diagnosis even before you ask for the investigation. Now, on the left-hand side, this is the boy of 10-year-old. His weight is 33 kg and height is 120 centimeter. So this is his weight and this is his height. So as you can see, his weight is on between 50th to 75th centile, but his height is 120 centimeters. That means his height is affected more. So he is a short and obese. Whereas on the flip side, on the right hand side, this is the second example of weight of 48 kg and height of 145 centimeters. So here weight is almost touching between more than 90th percentile, and similarly he is on the taller centiles. So once we plot this, you can see the first individual on the left hand side is short and he is obese. So his height age is just 7.2 years. In fact, when his weight is around 10 years, weight is around 10 years, as opposed to that on the right hand side, the height is spread. So it's relatively tall. So the point here to understand that whenever you're seeing a short and obese, the cause is nutritional or polygenic. Whereas tall and obese, the cause is nutritional or polygenic. So in left hand side case, when we examine, this was definitely endocrine cause. So TSH was more than 100. So this is the endocrine related obesity. So endocrine or syndromic obesity will always be short and obese, whereas a nutritional obesity, you will see a tall and obese. So again, emphasizing the same thing. The tall and obese will be a nutritional. So you don't have to run a battery of investigation if you see a chart which is tall and obese. But whenever you see a growth failure, you have to ask for the hormonal evaluation like thyroid or cortisol, or in case of insulin resistance, a fasting insulin is must. Now, I'm just going to show a few typical cases of particular etiology. So this was 11th month old girl. As you can see, she's extremely obese. You can see the skin fold. There was a weight gain since 1 month of age associated with extreme hyperphagia. There was normal birth history. Birth history was insignificant with birth weight of 3.5 kg. So on genetic investigation, she was found to be a leptin deficiency. So the treatment of such kind of obesity is subcutaneous dose of injection leptin, currently which is not available in India, but we can procure from the Western world. And it is a once a day or a twice a day dose, and they get completely cured. So whenever you're seeing a child who is less than 5 years, precisely when it is an infantile obesity, genetics does play a part, precisely when there is a family history associated with it. And some of them, they are amenable or they are having their own treatment. As in this case, leptin deficiency, the treatment of choice is injection leptin, and which is available at present. Now, coming to the second case, this 9.5-year-old girl, now on growth chart, she's short and obese. She's having the retinal changes, and if you see her hands and lower limbs, there's a polydactyly. So this is nothing but Lawrence Moon Bardet Biddle syndrome. Now again, you can establish the diagnosis by doing FISH or another genetic investigation, but it's a clinical diagnosis as well. So whenever you are seeing a short and obese, along with special senses affection like vision or hearing, you must think of a syndromic or a genetic obesity. Coming to a third case, so again, this 10-year-old boy is a short and obese. There is a growth failure. You can see the shape of the eyes. It's almond shaped eyes. Classically, he was having a micropenis with undescended testes. So a classic example of Prader-Willi syndrome. Now, please remember that Prader-Willi syndrome is a hypothalamic obesity, and interestingly, they have a growth failure symptoms during first 1 year. So there's a difficult, because of the hypotonia, they have a difficulty in feeding. But after that, they generally gets the extreme hyperphagia after 2 years of age. And this is what the Prader-Willi syndrome manifests. They are short and obese, often associated with hypogonadism. And if it is prolonged, then they have a condition called obstructive sleep apnea. So these are the prototype example, which is I'm showing. It's the last one. This is an 8.5-year-old girl, again short and obese. So endocrine cause. As you can see, the buffalo hump and hirsutism. She has a moon faces. So the diagnosis was Cushing syndrome. Her 24-hour urinary cortisol was way higher. So it was drug-induced Cushing, where we have to stop the exogenous steroid, which was on very high dose of Vicelone. So again, highlighting the same thing, that when one should suspect a syndromic obesity, whenever you are seeing a less than 5-year-old child and he who is obese, that's the red flag. So you also have to look into the dysmorphic features, vision or hearing, typical asymmetry if it is seen, the color of hairs, if there are a number of fingers that polydactyly, and whenever it is associated with developmental delay. So developmental delay and special senses affection in less than 5-year-old child with some family history points towards the syndromic or the genetic obesity. And just to confirm the diagnosis, you can ask for the genetic evaluation. We have genetics available with us in our country. Initially, it was not available. Now we diagnose the MC4R genes and other genes like PKK or MC4 or MC3R regularly in our country. At present, it is not cost effective, but when it is really needed, one can definitely ask for the genetic evaluation, and it does help. Now, how do you measure the obesity? There are either direct measure or indirect measure. Obviously, you have to calculate the weight and you have to see in terms of height, calculate the BMI. The waist circumference is much more better indicator of your insulin resistance or insulin sensitivity rather, as compared to your BMI, because BMI is just an absolute figure, whereas waist circumference give you an you have a same BMI. Meaning, relatively much higher, then the chances of developing a metabolic syndrome, that is type 2 diabetes or a hypertension, are much higher as compared to those individuals or those children having low waist circumference. Also, skin thickness or waist hip ratio use in some cases as a research purpose, but waist circumference is an easier method where we can do in your OPD practice, and we have the circumference charts available with us along with the percentile. So whenever it is crossing more than 70th percentile, that means you have to investigate for the complications related to the obesity. Now, as we said, now why that at 23 and 27 and not 25 or 30, where which is used in adult. So in Indian or also Asian, we are having a low BMI, a low muscle tone, and waist circumference. So we are more prone to develop insulin resistance as compared to the Caucasian counterparts. Also, they have we have high percentage of body fat as compared to the lean mass. Similarly, morbidities or the complications related to the metabolic syndrome, like diabetes mellitus or type 2 diabetes or hypertension or obstructive sleep apnea, they occur at much lower levels of BMI in Asians as compared. That's why we threshold is pretty low as compared to the Western population, and that's why we Indians are at much higher risk to develop obesity and complications related to the obesity. Now, when to suspect a metabolic syndrome or complications of obesity? So, whenever you are seeing a child whose weight is more than 27 cutoff of adult equivalent, that means crossing the orange line on the growth chart. Similarly, when there is a family history of obesity, cardiovascular disorder, diabetes mellitus, and on examination you see obvious signs of insulin resistance, that is acanthosis nigricans, which is easily seen on this picture on the back of the neck and on the flexural aspect. You have to suspect a metabolic syndrome and you have to work it up just to see if he has not developed the complications related to it. Now, why one need to worry about obesity? Because it's a multi-system disorder. It's just a root cause of multiple system affection. It can lead to a metabolic syndrome, which is also known as syndrome X. It is nothing but a harbinger of future type 2 diabetes mellitus and cardiovascular complications like hypertension and ischemic heart disease and stroke. It is also associated with dyslipidemia. So in pediatric age group, we are not concerned about the cholesterol that much as compared to the triglycerides. So if you see the definition for metabolic syndrome, it has a HDL and triglyceride and not LDL or cholesterol. That it's not given that much of importance. So in pediatric age group, whenever we are asking for the lipid profile, it's the triglyceride and HDL, which is the protective lipid lipoprotein that we have to be careful about. Along with that, it leads to a sleep apnea, PCOS, low bone mineral density, osteoporosis, osteoarthritis, and non-alcoholic fatty liver disorders. So it can affect multi-system. Similarly, it can lead to a lot of psychological imbalance, and they becomes a bully in their school. People tease them, so that again, that one more component, and then those individuals feel neglect or isolated, so they find the solace again in food. So it's like a vicious cycle. So that's why we have to address this issue at much earlier level. Now, what are the screening investigation that one should look into? So if there is a classic sign of insulin resistance like acanthosis nigricans, we generally ask for fasting sugar. Now, whenever the fasting sugar is crossing 100, then you have to ask OGTT. In pediatric age group, HbA1c is not a gold standard of investigation to find out the diabetes or impaired glucose tolerance. In fact, we have to do a OGTT, that is gold standard. The reason being, in pediatric population, it's more likely that we will find impaired glucose tolerance. That means your sugar between 100 to 129 rather than in a diabetic range. And that's the reason why you have to send them for the OGTT rather than asking for the HbA1c. Similarly, you should ask for SGOT, SGPT. Fasting insulin can be done when it is associated with acanthosis nigricans or other signs of insulin resistance. Lipid profile, along with clinically, you have to measure blood pressure percentiles because they are more prone to develop a hypertension. And it's not the case that they will only develop hypertension of 30 plus or 40 plus, but even in pediatric age group, we do see cases where they have, as a complication of obesity, they have a blood pressure which is going in the range of more than 95th percentile, which needs a pharmacotherapy for the controlling their blood pressure. Also, in female, you have to, and if there are signs of PCOD, we ask for serum testosterone and sonography just to see the appearance of polycystic ovary. And in those individuals who are having obesity with sleep problem, we ask for a formal polysomnography or the somnography just to see whether their apnea or hypoapnea index is at a particular level. Uh, in fact, it has much more, in fact, it's more prudent to do it in Prader-Willi syndrome because they are more prone for developing those apnea episodes. Now, how do we manage? That's the $1,000,000 question. Most importantly, first of all, prevention is better than cure. Lifestyle modification form the central part, and pharmacotherapy and surgery are a complementary to it. So, no treatment or the no pharmacotherapy will be complete or successful without help of lifestyle modification. Even the recent guideline says that you have to work on the family for good 6 months before you set them onto a pharmacotherapy. So ideally, they should work on their diet and the physical exercise. Along with, they should get some psychological help. And if it fails, then and then only you should subject them to drugs, which is also a few which is there in our hand. So as far as that, I think Dr. Priya will take over. But just to give a simple message that this is the typical plate should look like. You have to add more colors, no intermittent snacking. You should take a regular meal, water as a drink. One should eat whole fruit over the fruit juices and avoid overfeeding. Similarly, while eating, your electronic medium has to be totally switch off, and that is the most important thing for the weight stabilization. You have to add more fiber, and you have to consume less simple carbohydrates as much as you can, and recognize the eating cues and avoid overeating. That's the most important thing. Most of us, especially during the lockdown thing, whenever there's nothing, we generally find solace in eating. So we should avoid that practice. In fact, we should engage ourselves in other activities rather than just munching onto food when it's not necessary. Physical exercise is must, ideally for good 40 minutes. Optimal is 60 minutes per day, and it has to be continuous for at least 5 to 6 days in a week. You can do the things which helps the children, and it has to be patient friendly so that they don't get bored. And you have to reduce sedentary time as much as you can. Similarly, you have to have a good peaceful sleep for good 8 to 9 hours in pediatric age group. Lifestyle modification, you have to add more and more colors, as I said. Involvement of family is of paramount importance. So unless everyone is on same page, you will not really get the control of obesity in child. Just to give you an idea, most of the time when we see a patient, 70 to 80% of them, they often feel that they are doing everything. But when you ask them into the detail, it's just that they try to stop whatever food items or the carbohydrates just for that particular child, whereas whole the family is munching on it. So this is not how the obesity control will be there. The obesity control, it has to be on the not only on the individual level, but it has to be on the family level. In fact, when we talk about the prevention, it has to be at the community level as well. So everyone has to involve in the management of obesity rather than just restricting to a particular person. So very important, you have to restrict the screen time as much as you can. Now I understand that it is difficult in current situation where digital becomes a new normal, but still, as much as you can, you have to restrict the electronic screen time. AAP recommends that there should not be any screen time whatsoever for a child who is less than 2 years. And after 2 years, the AAP recommends that it has to be around 2 hours or less than 2 hours. And within that 2 hours, 1 hour has to be for his academic activity. Age appropriate exercise should be for 20 to 40 minutes, ideally 60 minutes. Now, what are the drugs which are available with us when the lifestyle modification generally doesn't work? So it's not a first line of management, and as we have covered that we only initiate after 6 months of trained lifestyle modification, and it can be given to ameliorate comorbidities or whenever there's a risk of insulin resistance and family history of type 2 diabetes and hypertension, ischemic heart disease in the family. We generally give it for 3 to 6 months. And what we anticipate is the percentage of BMI Z scores reduction of around 5% point when the lifestyle modification and pharmacotherapy is given in an optimum dose. So there are only couple of drugs which is available. Now, orlistat is the drug which is FDA approved and has to be given after 10 or 12 years. It inhibits the fat absorption. But similarly, that's the mode of action. And similarly, the side effects associated with orlistat is flatulence and fatty, greasy stools. So sometimes it becomes really annoying for the school-going adolescent. So that's why we have to warn them while we start them on the treatment with orlistat. Sometimes very often to reduce the insulin resistance, we use insulin sensitizer, which is known as metformin. Although it is not approved by FDA for the obesity management, but there are many literatures which is indicating the beneficial effect of metformin in terms of insulin sensitivity and preventing the future diabetes and hypertension. It can be given in low doses to prevent diabetes in pediatric age group. And the last one is leptin, which is not available in the country. It is only used in leptin deficiency, and it is given as a subcutaneous injection. Now, obesity prevention should be our motto. It should not be just restricted to a one child, but it has to be started from family. It should go to a school, community, and a nation. Ideally, we should have, as a country, we should have a nation-specific program, just like we have it in adults for non-communicative disorders. Similarly, it's the urgent. There's an urgent need for developing a nationwide program for pediatric obesity. And prevention should focus the young children, as we have seen that we should not pick those children when they are already morbid and more than 10-year-old. We should pick them when they are way before or less than 8-year-old child. Now, just to summarize, whenever you are seeing a growth chart and on the BMI percentile is more than 20, third adult equivalent, that means the line, the BMI point is crossing the orange line. Ask for specific history, examination, and anthropometry. Whenever it is associated with some CNS symptoms, it could be a hypothalamic obesity. Whenever it is associated with developmental delay or hyperphagia, you're looking for the genetic obesity. Whenever it is a poor growth failure, it could be a endocrine obesity. You have to investigate and treat. And when you're seeing a tall and obese, it is related to a nutritional obesity. You do a lifestyle modification, address comorbidities. If a continuous weight gain still persists for more than 6 months, add a pharmacotherapy, SOS, bariatric surgery as the last option, along with diet and physical activity. So just to summarize, whenever you are seeing a tall and obese individual, more often than not, it's a nutritional obesity. In case of short and obese, it's an endocrine. Asians have a high propensity to develop obesity and metabolic syndrome. Genetic evaluation does help us in children who are less than 5 year old and in properly indicated individuals. And our focus should be on prevention of obesity rather than just treating a single individual. Thank you so much.
Thank you, Dr. Prashant. I think that was a very, very comprehensive coverage of a difficult topic, and you have made it look simple. That
Thank you.
we should suspect causative obesity or obesity with a cause only when we are looking at a short and obese child.
Yes.
Usually, because the around 5% of the children you will be able to find a cause. Otherwise, 95% of them would it's difficult to identify a cause. So thank you very much. I think the last algorithm that you have shown will be very useful for family physicians to identify a child, because what we find is when the patient comes, by the time patient comes to bariatric surgeon, they have at least 15 to 20 thyroid reports, and even though each one of them is normal,
Yes.
and the patient's family keeps on saying that there must be some cause, and that's why we are getting all the tests done. Can you do some other tests to find out what is the cause? So I think it's very important that we use our clinical judgment based on the algorithm that you have provided to identify patients and to not unnecessarily get all the investigation done. So thank you so much. We have many questions coming for you. We will definitely be taking them at the end of all the talks today, because they are all overlapping questions, and we'll be asking different speakers. So our next speaker is Priya Karkare. Priya is a pediatric nutritionist and chief nutrition officer at Fly Technologies and Surya Hospital, Mumbai. Uh, Pediatric nutritionist is a very important role to play, because, as Dr. Prashant also mentioned, it is not only the child; it's the entire family which needs to be treated. And I generally believe that it's more of the family issue than the child's issue. So we had a young adolescent child who came for surgery, and he was some 185 kgs, and we were discussing that after surgery you will not be eating out, maybe once or twice a month you will eat out. And then when he was leaving, he said, but what will happen to my father? I said, what happened to your father? Well, he loves to eat out, that's why we go out. So I think the pediatric obesity, the child is one of the factor, and family is important, and that's why the nutritionist role is so important. Priya, please go ahead with the presentation. I think you are muted. We can't hear you. Yes. Priya, you have to unmute. Yeah.
Hello, can you
Yes.
hear me now, sir? Yeah.
Yes.
Thank you so much for the warm introduction, and thank you for this opportunity to be a part of this discussion. Uh, you very rightly said it is. I think 75% of the cause is the parent, and probably 25%. We'll see that through the lecture. Thank you, Dr. Patil, for so beautifully covering to identify the nutritional obesity. So that's why I've just named my talk saying that my child is just cute and chubby. So first of all, in our society, the acceptance of obesity has still not come in. It's still a cute, a chubby child, which the family looks at. Now, first of all, let me just highlight on why do we exactly need right nutrition? Physical growth and development, which I think is taken care of. Immunity building. So normally everyone says, I mean, especially during this pandemic time when everyone is running after immunity boosting foods, I'm sure Dr. Goyal and Dr. Patel agree with me that immunity is built right from childhood. So it actually depends on what you eat in your early days, which builds up your immune system. Brain development, again, this happens in the first 5 years of birth. We all have read in Mahabharata and about all the famous mythological stories that what the child learns when it is in the womb, and once in the initial 5 years when parents go out and teach everything. Now, of course, there is a lot of role of essential nutrients coming in from the diet for this development. And finally, to prevent non-communicable diseases, which is our highlight of the topic today. Okay, now if you look at CDC has given childhood obesity management, where they say between 2 to 7 years, if these are the BMI ranges, you more look at weight management and weight maintenance because the child is still small. And above 7 years or older is when you would look at weight loss unless there is a medical diagnosis. Now, a question to all of us, do we really think this is going to apply in the Indian scenario? Already we are picking up obesity at a much later stage in life, which can cause more complications. So let's see what happens in India. Now, the most important concept what children and parents need to understand, it is not about giving away junk food or not having chocolates, not having ice creams. I think this is a very, very basic concept which every parent and children need to understand, which is calorie in versus calorie out. There is no harm in eating. It's very difficult to refrain a child from eating, snacking on certain items. However, if we teach them the concept of burning that amount of calories, that's when it sinks into them. So weight loss will only happen if the calories that is going out is more than the calories that is taken in. Now, I think there is enough amount of awareness with Dr. Google, and I think general awareness of high fat and high sugar foods, which are very, very calorie dense. Now, what are the goals of the therapy? So first of all, like Dr. Patil has said, prevention is the key. And the family has to work as a team. He did highlight certain points which I am going to re-emphasize on. And what are the individual goals? Somewhere in my practice, what I always see that, parents can keep cribbing, the doctor can say, the friends can say, till it sinks into the child for himself or herself that I need to lose weight or I need to look better. I think there is no step towards that. Dietary modification, like I said, maybe portion control would be the best option here, and definitely increased physical activity. I think in the situation now where children are not able to go out and work out, but I think even within the house, there can be multiple physical activity movements that we can teach our children, probably do along with them. And most importantly, parents are role models. So, like Sir said, I had one child who had told me, mummy serial dekh ke wafer khati hai, so main bhi khata hu. So, this becomes so children speak and kind of reiterate what they see. And like medicines and surgery, definitely would be the last school of therapy. Now let's look at the food plate. So sir beautifully showed us the food plate, and definitely the trends are changing now. We are emphasizing more on salad, fruits, and vegetables, some amount of carbohydrate, because as a country we are very, very high on carbohydrate intake and probably limited on protein intake because of limited sources. So I think a lot of emphasis needs to be laid on definitely every meal should have a protein. So basic protein foods can be milk, dal, eggs, non-vegetarian foods, and sprouts. You have a lot of Indian millets which are also having good quality protein. And the good thing about Indian diet is the combination of cereal pulse, like probably khichdi in the north and the pongal in the south. So all these are excellent examples where the bioavailability of also increases. Now, I think over 90% of the parents normally crib that my child doesn't eat salads or doesn't eat vegetables or doesn't eat fruits. Again, it's all a matter of habit, and it's on how you develop it as a habit to the child. So the first point can be you become a role model and keep reinforcing the habit day in and day out. There can be cheat days, there can be days when you are having high sugar foods, but of course portion control there becomes the most important thing. Now, let's talk about little babies. So, right from even if they are newborn babies, it does correlate to subcapsular skin fold thickness, and that also correlates to truncular obesity. So, it's understood, it's scientifically proven that the fat cells increase in number in the first 5 years of age. That is why we always say a very chubby child or an obese child has possible potential to grow into an obese adult. So probably rewind yourself, think back how thin I was when I was a child or how obese I was when I was a child. So somewhere your fat cells have been already increased in number, and in the later stages of life, it is more of the size. However, there are a lot of unscientific theories which says it removes your fat cells off or decreases them in size. You require scientific evidence to prove these. Now, this is a life cycle wheel, so it show us the causes of obesity. So just like what I said now, if you are lean as a child and you ensure you ate healthy, you had enough amount of physical activity, you will grow up to be beautiful, lean adults. However, the unhealthy wheel also leads way into very, very unhealthy adulthood. Okay. Now let's look at what are the major concerns, feeding concerns of every mother today or every parent. Quality versus quantity. Now we are always fighting between the two, and I think making a balance is very, very important. Where definitely we need to give more preference to quantity and ensure that the high sugar and high carbohydrate foods are thrown out from the diet or probably limited in portion. Now, incorporation of foods, I think when the child is younger, like sir was saying, involvement of parent or parents are the culprit. Parents are the culprit mainly when the child is small. So, taking a 1-year-old child to a food court and introducing them to all the variety of food definitely is going to give more way into choosing the wrong kind of food. So that's basically, poverty in midst of plenty, where the foods are very, very poor in micronutrients and probably nutrients that are required for growth and development of the child. But of course, in terms of quantity, they eat it in abundance. In terms of food refusal. Typically, the parents decide that my child doesn't like the food or doesn't like salt and dislikes only sweets. So I think there, what parents need to do is keep reinforcing the food again and again, maybe in different forms, in different types, which will ensure that the child understands that this is what I'm going to get, and probably have to, go ahead and just eat that much. So where does the parent's role come? So using concepts like to avoid maybe sometimes food. So I remember as children, we always got a cake and wafer and samosa only during birthdays. It was very clear. It was a fancy food for us. But today, every day is a fancy day. Every fancy food is available just on a phone call. So I think, laying emphasis and teaching the children what is the right food, what are the more healthier choices. And like I said, as a country, we're very rich in the types of millets and pulses, and there is so much variety that we can offer. Now, talking about eating behavior, like I said, it starts about conceptualizing the behavior right from the early childhood days. Loss of control by eating, and here where gadgets play the most important role, which we will be talking about a little later. But the concept of food in a child, a child makes images about the food. Now, the moment you're going to give a burger and say, "Wow, this is a wow food," the child is going to go with that this is a wow food. And when they see the probably the thepla or the idlis or the parathas at home, and they're going to say this is like a staple food. You never say, wow, this is an upma for you, or wow, this is a dhokla for you. So I think reiterating those kind of wow factors even into our daily food is very, very important. Continuous consumption of high calorie food, which basically it does not fill the satiety value of the child, lack of proteins, and of course high sugars, which initiates the child to eat more and more food. And like we've been continuously saying, imitating parents. So to all parents and all the physicians, and I think it's uh, the big know-how is to parents of how they need to control the food before blaming the child. Now, I think we all are familiar with these kind of binge eating and watching, eating while watching the TV. The only thing I would like all of you to pay a thought on is while we are eating and watching TV, the remote control of the mind is with the channel. It's not with the child, and the child just doesn't know when to say this is enough. They don't understand that, this is the quantity I need to take. So if they've opened a packet of wafer like this girl on screen, you can see she just doesn't know, and she's just so enjoying this whatever she's watching on screen that there is no gut brain connection to say stop to her action. Now, dietary practices at home. One of the most important factor here is portion size, where I've seen a lot of mothers who come to me and say, my child doesn't even eat 2 chapatis or doesn't even eat 3 chapatis. What we need to compare is the age of the child and probably the quantity the child can manage to eat. So allow the child to ask for food, allow the child to ask for water. So making the child feel hungry and feel thirsty is very, very important. Today, we are so overprotective about children. Probably, in earlier times when they came back from school, it was assumed that the child is hungry and you've already fed a meal. And then the mother is sitting there, or, the caretaker is sitting there to ensure that the child finishes the plate. So this does not allow the child to understand, is my stomach really full, or do I have to just listen to mama's, enough, stop, yeah, you're hungry, yes, you need to have a juice, no, you have to eat this biscuit because you've not eaten anything from morning. So the child doesn't have the ability to understand, like probably, as they grow older, they say, no, I don't want this because I'm not hungry. So making them realize this in the earlier days of life is extremely important. Avoid binge eating and midnight snacking. I think as they grow into adolescence, this really takes a toll on their health because it breaks the circadian rhythm of the cycle. And definitely, these are all very, very high calorie foods, which are going to be extremely harmful for the child. And definitely, another quick tip, probably, which parents and all doctors they can try is if you're ordering high calorie food or, having a party at home, ensure you have a snack before you eat the high calorie food, and learn to share it among the entire family, so that, probably you don't order like one pizza each member of the family, but order probably a medium size and ensure everyone gets 2 pieces out of it. That's how you break the portion control. Now, quick tips including all food groups is very important. So every time you sit on the table or on, probably look at a plate. So some easy tips is if you've made a dal, try and make a green vegetable. So maybe a beans or a palak or a leafy vegetable to, complement each other, and maybe give a beetroot raita. So when the child sees colors, I think the attraction is a little more when they are young. And of course, as they grow older, it's definitely, to how the food is looking. So giving that variety of food and adding that colors to the plate. So maybe if you can develop small habits like putting 2 pieces of carrot right when the child is young on the plate, so probably the child picks that up as a habit. Now, involve your child. I think we all take our children to malls to shop for clothes, toys, gadgets. Maybe it's high time that we take them out for food shopping, teach them food, reading the food labels, probably identifying the high calorie foods, which is very important. I think as a mother myself, I always found taking my child to the market a menace because he's going to pull the vegetables down, or, when they are younger. But however, identification of the vegetables. So probably if you've marketed, and I'm sure we all would have done this during the lockdown, where the child is helping you clean the vegetables, put them the vegetables inside. So identification of vegetables and probably reinforcing them while you're sitting on the table. So positive enforcement on food is extremely important. Instead of just saying that if you've won or if you've done well in your exams, I'm going to treat you to a burger or I'm going to treat you to a pizza. Probably treat your child to an outdoor sport, or go for a run with him, go play with him in the garden. So, like Sir said, 1 hour of physical activity, and every time a child does physical activity, what you need to reinforce is what is it the high calorie food that you've eaten today, and you need to ensure that you burn it out for it. A very simple story which I would like to share with my own son. He loved Oreo biscuits. He ate, he could finish a packet. He's an adolescent now. He could finish a packet. And the moment I told him to burn calories of 2 Oreo biscuits, you need to walk 2 kilometers. That's when it was a big no to that, because these are very calorie dense, low in protein, and very, very high in sugar. So now when you start relating that if I am going to eat a very high calorie food, I need to work out, I need to run, or I need to play, and I need to sweat it out for an hour, it becomes very difficult. And probably they understand that language. And that sensitization is extremely important. Now, at the community level at Fitterfly, we took up one of the largest campaign for children, which was called Sahi Khao. This happened in 2018. We reached out to schools across India, and we ran competitions where schools reinforced on healthy eating. So to my children's school, I was called the Sahi Khao mom, because every day their tiffins used to be checked on what they got for lunch or for snacks. But I think that really made a big impact, and we had plenty of participants, and the schools kind of echoed eating right, and we sent this 10 commandments in terms of, the schools could sing it as poem to younger children, give it as fridge magnets to schools, put it up on posters. So I think it's not, once a year campaign, it's throughout the year campaign that we need to run and ensure all children follow the mantra Sahi Khao. So I know it's the era of digital, technology where everything is on the phone. So at Fitterfly, we offer digital consultation. So you can visit our website or call us for consultation. Now, the good thing about it gives you a one-to-one connect with us and ensures that motivation is there. So I personally believe these are my children, and every mom is a chef and a nutritionist to her own family. So I think just like in the lockdown, everyone has entered the kitchen and become master chefs at your house. Look at all the secret ingredients that is available to us in our kitchen and ensure that you utilize it in your daily meals and keep healthy. Finally, to take away, there are no revolutionary diets, no magic. And one of my dietitian colleagues who says this in every talk of hers, just zip your lip and move your hip. So that can be the mantra for everyone. Thank you very much for patient hearing, and over to you, sir.
Yeah, thank you, Priya. I think that was wonderful. When you were talking, it seemed as if this is my talk you are taking, because I have been talking on this issue for almost 20 years, and portion controlled eating, buying sensibly food products, and mindful eating, and being a role model. These are all the issues which are so important. I can understand how it is difficult for a parent to accept that they are the primary reason why there is obesity in the family, but
Right.
they are also helpless. In a metro city where the mother is also working, father is also working, they need to leave early morning, and they need to quickly pack lunches for two of their kids. And the easiest thing is to pack a snack item or a pizza piece, and move on with their lives. So I think it's a challenging topic, childhood obesity, and
Yes.
this requires a concerted effort. And as both of you have rightly pointed out, that the prevention is probably the best way of doing it, because once that orientation settles in a child's mind, that what is a wow food for him or her, it's very difficult to break that,
Right.
because now they are addicted to a certain kind of food, and then they are going to have it one or the other way. So I remember there was a study which was presented in International Congress of Obesity in 2009 in Sydney, and this was from a French village. So this is a village of some 6,000 people, town of 6,000 people, and they tried to control rising childhood obesity, and they said that okay, all the parents will give a healthy tiffin to the child. So the parents were taught, and the children started bringing healthy tiffin, and they evaluated 3 months down the line that obesity is not improving, because now the children were getting this from the tuck shop. So
Right.
the group went to the tuck shop and requested, please stop the unhealthy food, and they stopped the unhealthy food. Still, the obesity didn't go down. The children started going out of the school and buying things from nearby shops. So then those shops were too requested, because it's a small place, one or two
Right.
shops. They stopped, but still it was going up. Then they realized the supermarkets are selling food which ultimately ends up at home, and the parents and the children, everybody is eating, and they could request the supermarket, and then the obesity stopped. So I'm not
Right.
saying that we are helpless or this can't be done. This can certainly be done, but it's a very challenging aspect, and probably prevention is the only way. And
Right.
where parents play being a role model, if you adopt healthy habits, you can bring up healthy children in long run. So now I'll talk briefly about bariatric surgery, because if you can't prevent it, and if the physician and nutritionists are not able to control the obesity which is already there, or if they lose weight and it keeps coming back, then one of the option for some small number of children is what is bariatric surgery. And I'll okay. So I'll share my screen, and all right, I hope you are able to see this slide. This is our Centre for Metabolic Surgery, and I am doing bariatric surgery for last 20 years, and I was president of All India Association for Advancing Research in Obesity from 2007 to 2009, when we were discussing the obesity related issues all over the country. So today we are going to talk about bariatric surgery in children and adolescents. So as Dr. Prashant showed initially, that at 27 percentile, the BMI in India is about 27. And we say that bariatric surgery or a severe obesity is when the child's percentile is more than 99, which is equivalent to an adult BMI of 30. So we are looking at surgery for these children who are 99 percentile and above. Why we are looking for this considering
Excuse me, Dr.
surgery as an
Goyal.
option? Because these children are at a very high risk of cardiovascular problems in long run.
Dr. Goyal, your slides are not visible. Sorry to interrupt you in between, but your slides are not visible.
Okay, so why they are not visible? All right, sorry. Allow the app to record the content of your screen. I'm the only one who has not tested. Are you able to see my desktop?
Nothing as yet. We are able to see you.
Okay. All right. This is opening nicely. So should I go out, slide share, I stop, and then we try to do this?
Yes, please.
All right. It is asking, okay. It's asking me open system preference, allow Zoom to share your screen. Open
Right.
system preferences. And then comes Zoom US. Okay. This, I have done the. This is something new. I have been using this. So shall I can actually see my own slides and talk about them. It's really not necessary. Or Okay.
Okay.
Or what we can do is, if you can just hold on for a minute, I can send the slides to you.
Yes. So
Time.
until then, we can take a few questions if that's okay.
Yeah. So, Dr. Prashant, you can see the questions on the in the group, or Dr. Kritika, you can read out the question.
Sure, I can do that.
Yeah. Yeah. Please do that. You don't take the bariatric questions.
Yes.
Yes.
Just a second. Okay. So the first question is, can you elaborate on a few of the nutrition models that can be used for managing obesity in specially able children?
This must be for Priya.
Yes, Miss Priya.
Yeah. So I think it's a question for both of us because, first of all, identifying the cause of the obesity, because maybe it may be movement impairment, or, if it's those kind of causes where physical activity is completely restricted, then we have to cut down calories and work more on protein and fiber and other nutrients, and ensure the satiety mark for the child is felt. And especially in specially able parents are a little more emotional about food, so they just want to give food as a reward every time they do a therapy, or there is a small achievement. So maybe refraining from those kind of activities and choosing the right kind of carbohydrates. So more complex carbohydrates, blend of carbohydrates and proteins, lots of vegetables and fruits which are low on calories but high on micronutrients, adding nuts and seeds to the diet in different forms, cutting down sugars. So maybe, these few steps can be helpful.
Okay. So the next one is, in the case of twin siblings, is there any specific connection owing to the obesity in one of the two?
Yeah, so interesting question. Definitely, there's an association of obesity in one kid. There are a couple of mechanisms which has been postulated. One is mitochondrial disruption in one particular individual, and other twin is having a good mitochondrial function. That is one of the cause. Second, those are born SGA, that means small for gestational age. And if they're during feeding, during their formative years, if you try to overfeed them, then there is a high propensity to develop them into a obesity and future diabetes, which is also known as Baecker hypothesis. So those who are born as a low birth weight, that is less than 2 kg or 1.5 kg, you don't have to overfeed them. Otherwise, that will lead to obesity and metabolic complications. And coming to why one particular twin is affected with obesity, there was one beautiful study was done in Scandinavia where they have taken 18 identical twins and they have separated into a 9 as to 9 counter twin. And classically, in all 9 form of 9 twins, they are having obesity markers, and others 9 twins were metabolically pretty active, and they have given the role of mitochondrial disruption in the fatty individuals or the fatty side of the cell. So I think that's the cause of obesity in some twins where the other twin is related.
Okay. You diet in children possible? Does it cause any other health related problem?
subsequent generation will see a morbid obesity, that is BMI running more than 30th adult equivalent at much younger age as compared to the subsequent population. I have two such families where the grandparents is also 90 plus or 100 plus, father is 100 plus, and the child at age of 7 years is around 70, 75 plus.
Oh.
So yes, hereditary does play a part, a role, but also it depends on what is the dietary pattern of whole family. That also plays an important role, and in fact, that is far more important or more common, I would say, as compared to the just one particular gene. So both these factors plays important role.
So, Dr. Prashant, now this question is from me. So, if there is a family with obesity, should they get their children tested, or should they do something right from the childhood to make sure that the child doesn't become obese like themselves?
So if provided, if the lifestyle intervention fails for good 6 months, like we generally give them a chance, we ask for their dietary patterns in detail and give them a proper regimen of diet and physical exercise. Despite that, if there is a history of bariatric surgery in one or two generations, or there is a history of death due to cardiovascular event in around less than 50-year-old, in such an individual high risk children, we can ask for the genetic evaluation just to find out whether they are at a particular risk of monogenic obesity.
Okay. So ultimately, even if it's genetically determined, not a genetic obesity, hereditarily acquired obesity, the treatment remains the same. Or rather, you should be more proactive in terms of preventing the weight gain.
Yes, there are
Better to
certain newer drugs, sir, which is still in the pipeline, like MC4R agonist, some of the SGL2 inhibitors. Now, US FDA has approved for them for the usage in 17 or 18-year-old children. So there are some drugs in the pipeline. Maybe in future, at least at present, when we have the diagnosis, for all such research, research-induced drug activities will only be possible when they have a genetically proven diagnosis of particular gene, and then only we can try those newer drugs. So hopefully, maybe in a decade or so, we'll get the drugs for that genetic obesity.
Okay. And what about these leptin injections you mentioned? There was a time when they was talking about leptin added in bread and given so that So how expensive are these injections, and what is the number of leptin deficient patients in a country like India? What would be your guess?
So
Just to
maybe less than 0.01%. Like I have one case only, and Dr. Khadilkar sir had around 3 or 4 cases. So
Yeah.
not many. And when it comes to the cost, it is available maybe in USD, so per unit or per mg. I'm not too sure about unit or mg, but 10 mg injection will cost you around 700 to 800 USD.
Okay.
You have to procure it through procuring is an issue because there's a custom approval from the US or the UK, but you still get it somehow. Sometimes
Yeah.
you have to send the patient to UK or US, give them the treatment.
So
Dr. Goyal,
yes.
sorry, we are ready with the presentation. Should we go ahead or
Yeah.
do you want to complete it?
Let's do it. Let's do it.
Okay, just a minute. I'll just share my screen. Yes. Please just say next whenever you want me to go ahead.
All right, you can go to next. Yeah, so friends, rewind of what we started with. So today we are going to talk on bariatric surgery in children and adolescents. Next, please. Next slide. No, you'll have to go back. I think you changed 2-3 slides. One more. Yeah, okay, next. So the severe obesity, or when we say it's a 99 percentile, is equivalent to adult BMI of 30. And the reason why it is done is, or advised is, because these are the children who are at a high risk of cardiovascular problem. In a country like US, 4% of children are morbidly obese or above 99 percentile. This may look a small percentage, but this is This is a huge number when you see a country like US, and it's a huge number, bigger number when you see a country like India. And even in developing countries, there is a 60% increase in prevalence of childhood obesity in last 15 to 20 years. Can you go to next slide, please? It is also seen that in these children who are 99 percentile and above, lifestyle changes do not cause substantial weight loss. And even if the weight loss is achieved, it's almost impossible to maintain it over 1 year. So the overweight and obese adolescents are known to have increased mortality with coronary heart disease when they become adult. So I think what is important to realize is that the foundation of coronary heart disease is laid during the childhood or during the adolescence. And this is higher, and we are already seeing a large number of adults in India who are having a coronary disease between 30 to 40 years. And people say that it's because of the smoking or because of pollution, but probably this person was obese when he was like 13-year-old or 10-year-old. And it's also seen that there's an increase in all-cause mortality in white adults, in those who were morbidly obese when they were children or adolescent. Next, please. So, where do we advise bariatric surgery? To whom it should be advised? So, important thing to realize is we are talking of adolescents for surgery. We are not talking of children for surgery. They should fulfill all these criteria. Number one is that their BMI should be more than 40 with serious obesity-related comorbidity. And these are serious comorbidities we all know, diabetes, obstructive sleep apnea, hypertension, or coronary episode. They have attained adult stature. That means they have reached their adult height. They have tried various conventional management attempts. They have gone through that and they have failed on them. The child is able to understand that they have to undergo a psychological evaluation. They should be ready to follow post-operative nutritional guidelines, and they must have a decision-making capacity. So I have seen in last 15, 17 years that the parents bring a child who is 17-year-old and saying that she must be made to lose weight, do something for her, do a bariatric surgery. And she says, I'm fine, I don't want to undergo a procedure. Now, this is a child where surgery or a procedure should be avoided, because child must be able to earn that surgery or must be able to take a decision to get the surgery done. So next slide, please. So as far as bariatric surgery is concerned, these are the three commonest surgeries in India. The first one is sleeve gastrectomy. The second one is Roux-en-Y gastric bypass, and third one is mini gastric bypass. I'm not going to discuss in detail these procedures. Next slide, please. And then there are endoscopic procedures like a gastric balloon or a gastroplasty. So gastric balloon is self-explanatory. A balloon is placed in the stomach and which helps the child lose weight. And gastroplasty is when the stitch is placed inside the stomach to reduce the size of the stomach, and it shrinks as seen in the last picture. But these endoscopic procedures are primarily more cosmetic in nature and are generally not advised for children at this age because they do not cause long-term weight loss. So we are talking only about bariatric surgery and not about endoscopic procedures to majority of the children. Next, please. Now, I'm going to show you some important studies which have confirmed that how these surgeries can be done safely. So this is a meta-analysis of 23 studies only for adolescent patients, where the BMI reduced by about 13.5 points after all these surgeries combined, bypass, sleeve, and bend. While the maximum BMI loss was with gastric bypass, a decline of 17.2 BMI points at 1 year. Next slide, please. This is another study, very interesting study, where they had 108 children whose BMI was 49, and they compared it with 114 adults who also underwent bariatric surgery, but their BMI was 32. and they found comparable percentage weight loss at 2 years. So it's almost 65% versus 69%. So bariatric surgery, even in children, works equally well as in adult. This is the message that came. And they said that in another study, there were about 225 adolescents who underwent sleeve, and 90% remission of comorbidities, whether it was obstructive sleep apnea, hypertension, type 2 diabetes, and dyslipidemia at 2 years. And this is the strength of bariatric surgery. This not only weight loss, but remission of comorbidities. And the most interesting part of this second study was that the normal growth velocity was achieved in all these children, even though 1/3 of them were below 12 years. So the surgery was offered in those children who are not attained their adult height, but still they continued to grow even after bariatric surgery, and they attained the normal height. Next slide, please. Next, yeah. And this is just to show you two of our patients. These brother and sisters, they came to me about 8 or 9 years back. The elder child was a boy who is 206 kgs at 13 years. And his younger sister, who was 9-year-old, was 155 kgs, referred by a government from the Middle East. And the boy was already diabetic when he came to us, had hypertension, and both the children had bored legs because of the osteoporosis and excessive weight. And we operated them, even though the girl was just 9-year-old. And this is the girl is in Parda now, so we can't get her pictures. But this boy has lost almost about 73 kgs and is a working person. He plays football and is an active person. So, the surgery, even though the height, this girl was 9-year-old, it was offered because she was not even going to school because of attached stigma. And now she was able to attend school once she has lost substantial weight. Next slide, please. So I'm going to show you 2 or 3 very interesting studies, international studies. This is called Teen Labs Consortium, which started in 2007. It's a prospective study to measure efficacy and safety of bariatric surgery in adolescents. So overall, about 240 children in many centers across the world, 17 years average age, and with BMI of 53. They said that when they did a gastric bypass, the mean weight decreased by 28% and 26% with sleeve, which is almost same. But the important thing is that even after 3 years, they were maintaining their weight. And more important than that is 95% of those who had diabetes were in remission, that they did not require medicine for diabetes anymore. And as we know that a good number of them have abnormal kidney functions, they improved in 86%, dyslipidemia settled down in 66%, and hypertension settled down in 74% of these children. And these are ongoing studies. Next slide, please. And there is another study which started in Sweden, multicentric prospective study, though it's a non-RCT studies, where they did gastric bypass in 81 adolescents, and they matched it with 81 adults who had gastric bypass, and they had another group which was a conservative, conventionally managed controls. And they found at 2 years after surgery, weight loss was minus 32%. I mean, they lost 32% of their weight in adolescent, 31% in adults, while in control group, they gained weight by 3%. And the same group published another study after 5 years. They said that the weight loss continued at par with what was there at 2 years, while the control group continued to gain weight. But more important than the weight loss alone is that 100% of those who had diabetes and blood pressure, they had resolution of that. 82% had resolution of dyslipidemia, and 92% had normalization of liver function. Next, please. This is a study from Cincinnati Children's Hospital, and myself and Dr. Ketan Parikh from Mumbai, we went there for our training in adolescent bariatric surgery, I think almost 9 years back. This is called the FABS5 follow-up of about the patients, adolescent bariatric surgery patients. They followed up patients, 81% follow-up rate of 58 bypass patients who had a surgery between 2001 and 2007, where BMI was 58.5 before surgery. After 1 year, the BMI reduced by almost 23 points, and which was maintained even after 8 years at a mean of almost 17 BMI points. And then they said that in addition to weight loss, there was a statistically significant decline in prevalence of metabolic syndrome. So after 8 years, blood pressure was seen in 19 versus 47% at operation, dyslipidemia in 38 versus 38% versus 86% after 8 years, and diabetes only in 2% versus 16% after 8 years. But important thing to realize is that 63% of them still remained obese. So their initial BMI was about 58.5, and after 8 years, they were still about 35 BMI. And the interpretation of this was that there is a strong correlation between what was the BMI before surgery and then its long-term follow-up. So if the surgery is offered early, if these children were not 58 BMI before surgery, if they were 41 BMI or 42 BMI, probably they would have been normal weight after surgery and not still obese. So the surgery should be done at a lower BMI so that their BMIs become completely normal in long run. And that is the outcome of FABS5 study, and it's still ongoing study. Next slide, please. And why these studies are important? Because it is seen that for every 10 BMI increase, there is a 34% increase in dyslipidemia, 46% higher risk of blood pressure, and 25% rise in insulin concentration. And we also know that as cardiovascular complication occurs over years of exposure and then atherosclerosis happens, in children where their obesity is occurring early, there is a increased risk of premature death from cardiovascular risk. This is the same thing what Dr. Prashant and Priya was saying, that early obesity is more dangerous than obesity which is happening later. So it's an added responsibility on parents that they take care of nutrition of their newborns so that they don't gain weight, because it will reflect when they become 30-year or 40-year-old whether they will have an early heart attack. Next, please. Then adolescent diabetes. So we are talking about obesity. Now we talk a bit about diabetes. Adolescent diabetes is more aggressive than type 1 diabetes because it is seen that they have more early renal complications compared to type 1 diabetes. So this study, which was published in Diabetes Care in 2012, shows that 6% of them will develop renal failure by 20 years. And 2.3% will develop end-stage renal disease by 29 years. And this is what I am always outspoken about this, that if I develop diabetes when I'm 61-year-old, I will probably develop a renal failure when I'm 75-year-old and will develop end-stage renal disease by when I'm 85-year-old. But these children who are developing diabetes when they are adolescent, they will probably end up with diabetes complications and they will have to live with it for next 50, 60 years. And these people will require, these type 2 diabetes will have more insulin requirement early than compared to type 1 diabetes. Now, the flip side of it, then when we do a bariatric surgery, it increases insulin sensitivity by 4 times in adolescent, both in those who have diabetes and those who do not have diabetes. So Roux-en-Y gastric bypass improves insulin sensitivity substantially. And it is seen that greater remission of diabetes in adolescents compared to adults. Probably because they had obesity for shorter duration and the severity of disease is less by the time they present for surgery. So adolescent surgery in adolescents for diabetes is more effective and gives long-term benefit to the child. Next, please. Then we come about liver disease. We have discussed all these issues in different webinars for adults, and today I'm covering all of that for the children. In adolescents, when they come for bariatric surgery, and if you do biopsy in this study, it has been shown that 59% of them have fatty liver, with mild fibrosis seen in 18% of them. Now, this kind of a study has not been done in children, but what has been seen is in adults that after bariatric surgery, there is a fatty liver improves in 90% and fibrosis improves in 65% of patients. We don't have similar data in children, but this AMOS study, which I referred earlier, have shown 90 to 100% resolution of the liver hormones at 5 years. So there are now this is what is the interpretation of this is that if we intervene early in children, this will prevent progression to NASH, progression of fatty liver to NASH, and it may normalize inflammation and it may prevent fibrosis in NASH patients. We don't have evidence to that effect at the moment, but I'm sure there are studies being done and we will be able to share that with you in future. Next slide, please. Now, one of the important thing is obstructive sleep apnea in adolescents, and we know what obstructive sleep apnea. They are snoring, they are lethargic during the day. It has immediate consequences because these children have poor school performances and they are irritable during the day. And it has long-term consequences of the high blood pressure, left ventricular hypertrophy, increased cardiovascular and cerebrovascular morbidity and mortality. These are all evidence-based documentation that I'm sharing with you. And it has been seen that after bariatric surgery, there is a marked decrease in severity of obstructive sleep apnea in all patients. And there is a study which has shown 40% reduction in apnea score at 5 weeks compared to control. In adults, we have enough publications to show that there is a 93% remission of obstructive sleep apnea after bariatric surgery. So I think obstructive sleep apnea is one of the determinant of education and employability for adolescents. And those who have it and they are 99 percentile and above, it's a good idea to offer surgery to them so that it's not only a question of treatment of disease, it's a question of their long-term survival. Next, please. And then there are psychological issues. They are more profound in a child than an adult because they have low self-esteem, they have poor quality of life, and more depressive symptoms are identified in these children. They have low education or training, and weight-based victimization and stigma is very common. It happens in schools, not only from children, even teachers, and it happens at home also, where people think that this person is gaining weight because he's at fault, and it's a major issue that we face. There are studies which have shown that there is substantial improvement in psychosocial well-being in adolescents 2 years after gastric bypass versus control, and it leads to reduction of anxiety, depression, anger, and behavior improvement. And all these are known because there is an improved self-esteem. So I think offering bariatric surgery in those who are indicated early is important, because anything less than bariatric surgery, let's say a gastric balloon, may look logically very simple, but what happens, and I have faced it myself, and we offer when the parents insist on something less aggressive, that if the child doesn't lose adequate weight, he feels that he has failed the procedure and he feels that he has failed his family because family has spent money and family is anxious. While the child is not at fault, it's the wrong selection of procedures. So it's very important that a procedure is selected based on a professional advice, because child wants to prove himself right. One child wants to show that he can lose weight substantially after a procedure. So best procedure should be offered, not overcoming the fear and anxiety of the parents. Next slide, please. Just to show you this child who was about 17-year-old when he came to us, and he was not even ready to come for a consultation. When he came for consultation, He refused to stand on a weighing scale in presence of his parents. We could only get his weight when everybody was moved out of the consulting room. And now he lost weight, almost about 60 kgs. And he's such a confident young boy, and is working in a company now, and a productive person in the family. Next slide, please. Then there are many other improvements, like improvement in kidney functions, significant improvement in musculoskeletal pain and mobility. We all know that there are cancers which are associated with obesity. Since obesity in adolescent population is increasing last 30 years, we don't have long-term follow-up data, but we know that in adults, bariatric surgery reduces cancer risk by 30 to 80% over 10 years. So if the same thing applies on children, it will probably be even more, because the hormones become normalized much earlier in life, and the risk of cancer will reduce. Next slide, please. So friends, it's not that everything is positive about bariatric surgery. There are areas of concern. There's a study which has shown that despite all counseling and advice, only 14% of these children who undergo surgery, or adolescent who undergo surgery, continue to take supplement, which is a major concern, because we expect them to take supplements lifelong. And so as far as adolescent surgery is concerned, the role of nutritionists, psychologists is even more in bariatric surgery to encourage compliance. So I believe this surgery should only be done in dedicated centers which have a completely evolved program, which can monitor these children closely to ensure to avoid a complication or deficiency in the long run. Next slide, please. So to conclude, pediatric obesity is increasing in prevalence and severity. Adolescent obesity increases mortality due to associated comorbidity. We have seen that adolescents' bariatric surgery is reproducible, has safe and effective results, and it not only causes weight loss, it helps in resolution of comorbidity, almost at par with adult surgery or maybe even more. And the major improvement happens in health and psychological well-being of the child. The possibility of vitamin-related deficiency is higher in these adolescents, but that is a matter of compliance with the active support of a bariatric program which is treating these adolescents. We should be able to take care of these issues in these children. Next slide, please. Just to show you this young boy who came to us again a few years back. He was 120 kg. He came down to 56 kgs, and this is almost about 6 to 7 year old. And nobody can recognize him when they see his old picture and a new picture. They don't look like the same pictures of the same person. Next slide, please. So thank you so much. We do these bariatric surgeries at a center of excellence at Mumbai, and we'll be very happy if a child who is suffering, and this is more of a moral issue and a psychological issue, I take it. The youngest child in India, the Indian child we had done, was 13-year-old in Bangalore. The child was not going to school for 2 years, and a lot of questions were asked. A young girl, the questions were asked to me why I operated this child. I'm talking about 10 years back, and that child started going to school. She started participating in plays and has a social and educational upbringing at par with other children. So thank you so much. Dr. Kritika, can you stop the screen share? Yeah. So I think we can take few questions now. And okay. This question I think is for Dr. Prashant. Can physical activity reduce the level of butyl cholinesterase of obese children? So I think
very interesting observations. As a butyl cholinesterase,
yes.
it exists in 4 isoforms, so it does play a role in obesity. and physical activity tend to reduce it, but there's only a couple of studies which said that it is not a statistically significant reduction. But I must compliment a particular delegate who has been so keen in going into the research. So that butynyl cholinesterase and those four isoforms, they tend to marginally reduce with the help of extensive physical exercise, yes, but not statistically significant.
So, Dr. Prashant, I'll tell you, I have been repeatedly amazed by the knowledge of family physicians in Mumbai
Yeah.
and elsewhere. They attend more lectures of different specialties and multiple lectures of the same specialty. So, a family physician would have probably attended 50 lectures of a bariatric surgeon, while you would have probably attended 2 or 1 in life.
True.
So they are so well informed, and it's creditable
Yes.
that they know this. Yeah. Okay. How can parents be counseled to recognize obesity risk in their children? So this is for both of you. I mean, Priya, would you like to take it first, because you have these parents approaching you? How do they recognize the risk
Yes.
factors?
So, sure. I think, sir, I would completely go by the growth chart, because I also have a habit of plotting it on the growth chart. And what happens is I echo what the pediatrician is showing them. So pediatrician marks it on the file. I have the app on my phone, which sir had shown, and I show it to the parents. I show them what is the 50th percentile, growth curve. I also look at the growth trajectory, which I've learned from the pediatric fraternity. Like, if he's following a particular growth trajectory, and somewhere if you feel he's deviating, so what was the weight maybe 6 months back, 8 months back? Is it rapid weight gain? Is he maintaining BMI? Because a lot of parents, especially during the 10 to 12 years, when the growth spurt is happening, somewhere I think some amount of obesity sets in largely at that time. One is the food habits, and one is parents kind of tend to ignore it because they say, "अरे बढ़ता बच्चा है, ठीक हो जाएगा, baby fat अभी निकल रहा है," those kind of normal understanding. So
Okay.
I think the growth chart is my biggest marker.
No, but that
And
is for
of
the
course,
doctors. That is for the
sorry,
doctor. But if a family is coming to a doctor, how does he tell the family what to look for as a obesity risk factor?
okay, so it's a quick dietary recall. If we can look at the 5 food groups, what the child is eating, and how many times is the child eating. So main meals versus small meals in terms of snacking, and types of food that the child is snacking on. And somewhere we need to dig a little deeper into types of food that is available in the house. So many times if the fridge is stocked up with chocolates and ice creams, and maybe cola beverages, so the child tends to snack on these items more. So identifying a little family practices, and normally the justification that the parents give is हमारे घर पे बहुत guests आते हैं and we are a joint family. So maybe identifying these loopholes and reinforcing on dietary food groups. So maybe the 5 major food groups and portion control.
Okay. Dr. Prashant, one interesting question: how to treat hypothyroidism related obesity in adolescent? So I wanted to ask that question to you. What is the contribution of hypothyroidism in obesity? Let's first clear that, and then we talk about treatment of hypothyroid related obesity.
I have covered that partially in my talk. This was around less than 5% would be maybe approximate. We see an n number of reports of T3, T4, and TSH in any obese child. That's fine. You can still find a subclinical hypothyroidism. So if it is only a marginal TSH elevation, when your T4 is absolutely normal, one should not treat such individual with the thyroxine. It is rather the effect of obesity rather than being a cause of obesity that you will have a TSH increment which is just about 5.5, 5.9 or 6.2. And it is related to the leptin increment which is there with the weight gain. So it is body's attempt to increase the metabolism by increasing the TSH. Now, if it is a genuine hypothyroidism, precisely in adolescent, we generally do the antibodies against thyroid, that is anti-TPO and anti-TG antibodies. So if they are positive and your TSH is around 10, we then treat the child on thyroxine. We start with a minimal dose of 25 and we slowly titrate, and we repeat T3, T4, TSH every 3 months.
So anybody, okay, I'll just explore this little more for clarification. Anybody who is diagnosed with hypothyroidism, physician is treating with the thyroxine. Now, this weight gain of whatever kgs, how much it will come down? So once the TSH levels become normal on thyroxine treatment, you have titrated, you have adequately treated, and the medicine is regularly taken. Now, if you say that the child has gained 8 kgs because of hypothyroidism, will he lose that 8 kgs?
No. So it is generally, sir, 10 to 20% that is attributed to actual hypothyroidism weight gain, whereas rest 70 to 80% is probably due to overeating. So that only 10 to 20% weight loss will be happening, and that you will see a drastically within initial 3 or 6 months. So after 6 months, when he is absolutely euthyroid, there may not be any significant weight loss which will be occurring after 6 months. So as to coming back to your question, so if total weight gain is around 8 kg, probably and provided he is a genuine hypothyroidism kid, he will lose maybe a couple of kgs rapidly within 3 months. But after that, the journey of 6 months weight loss will be an extensive for another couple of years.
So I think this is very important point that you are making, because this is a misconception which has been propagated by some diagnostic centers, that you are gaining weight, so probably you are hypothyroid and you should come and get your thyroid tested with us. That even physicians believe, and this should be clarified, that once you have started adequately treating them, continue with thyroxine because he's hypothyroid, but don't expect weight gain beyond 2 to 3 months.
Yes.
Okay. All right. So one question for Priya for you. What role can food supplements play in controlling childhood obesity?
So I am kind of not for any food supplements, because I would believe there is adequate nutrition coming in from our normal food if the child is able to eat a balanced diet. And sometimes prescription of these food supplements or they can have adverse effects because the child will eat food beyond these supplements also. So then, tracking that becomes very difficult. So I would not really advise any food supplements for weight loss. Maybe we may take some support for weight gain at times, but not for weight loss.
Okay, I think that's very clear. Dr. Prashant, how important is measurement of waist circumference in obese children? I think you have already highlighted that. And so we'll skip this question. Priya, role of intermittent fasting in children, the role of intermittent fasting in adult is questionable. Why would you make a child do intermittent fasting?
But I have I have a statement to say here, sir. Yeah. But that, if you look at our Indian practice, probably if we had an early dinner and, probably the next meal is morning 8 o'clock for the child, and probably the dinner is early by 7:30, we're already doing a 12-hour fasting for the child. And that's why I had mentioned that midnight binging or midnight eating should be curbed. So it's not intermittent fasting, but putting the child through that many hours of fasting, which if he's eaten at 7:30, 8 o'clock, and probably the next meal is at 8, even that is good enough for a child. For adolescent, there have been scientific publications. They should not do 16 hours of fasting. Especially should not do the 16 hours of fasting, or should not get into any kind of keto diet or any kind of fancy diet, because they can have really adverse effects, because there are no prolonged studies happened on these, that what will happen to them after this rapid weight loss and the yo-yo effect and things like that. So no IF for
Okay.
children.
There are many questions. One is about this genetic evaluation, where it can be done and the cost.
Okay, so a couple of the centers like Sandor or Gene Cell or other labs, they are there, and you just have to collect the sample. But provided, I would recommend that first it has to be evaluated by your endocrinologist or the pediatric endocrinologist whether you really need it, and it costs you around 25 to 30,000. It depends on what test that you are asking. If you are doing just for a fish, it can get it done by just 6,000 to 7,000 bucks when you're asking for fish. If you are looking at much more spectrum and elaborative report of clinical exome sequencing, then it may cost you in the range of say 20 to 30,000.
Okay, all right. Priya, there is one question for you, and the question is that if predominantly casein-based drink is prone to cause obesity, How is it that we are having rural children or adolescents taking much of cow's milk? Hardly any of them are obese.
Okay, their physical activity is much more than probably what we will see in urban. In urban population, I think milk becomes the golden drink, and parents, especially when children are young, they overfeed them milk, thinking that it's very important for growth and development. The only nutrient that milk lacks is fiber, and kind of gives you a fullness because of the protein content, protein and fat content. So the child may actually drink a full glass of milk and maybe skip the subsequent meal. So and physical activity directly is the difference when the child is in an urban versus a rural. And of course, the quality of milk, there they may having more fresh milk probably directly from the cow, and no controversy of A1, A2, diluted, packed, those kind of things. And they're running on the fields all through. So I think their obesity is directly related to active physical movement.
Okay. Dr. Prashant, a question from a parent is that how do you determine ideal BMI of a 10-year-old boy or a girl? So how can a parent calculate BMI? They know how to calculate their own BMI, but for a child, how do they calculate the BMI? Is it the same formula or different formula?
Formula remains the same, but for if he's talking about the ideal, the line is dynamic. The 23rd and 27th line is dynamic. So for a roughly for 10-year-old boy or a girl, I would say 16 or 17 would roughly be the normal. And once you cross that 17, I think he or she will fall in that overweight zone. Just to simplify, if it is for parent, I think I would recommend that you should download that IFP growth chart app, and you just have to select the gender, weight, and height, and you will get a ready-made BMI as well as the interpretation of it. And you have to see to it that your point of BMI should not cross the orange or yellow line or red line. So it's the easiest way.
Okay. Okay, there is a question from me. As obesity is increasing, what are the drawbacks in some cases post-surgery? So I think nobody advises bariatric surgery in a child who is just 5 kg overweight, or who can be managed with diet and exercise, and who should be managed with diet and exercise. So we are only looking at those children who are above 99 percentile and who are not able to maintain their weight for various reasons. Now, obviously, any intervention has its pros and cons, and we tried to discuss that today. But generally, in a indicated child, it has substantial benefit. But the children need much more support. So just like how the nutritionists take care of the whole family, bariatric surgery needs the support of the family, and they need to be counseled much more so that the surgical outcomes are better. Otherwise, the child will have a problem if the parents are eating buttered chicken and they ask the child to eat a dry meal. So I think it's always a package thing. Whether it's a nutrition or bariatric surgery, obesity is almost a package thing where everybody in the family and even friends should support. And generally, there are no drawbacks in long run. Okay. So these were few questions, and we have another series of questions. Okay. Doctor, these are come after my talks. Dr. Prashant, few more questions. How are thrifty genes linked with obesity in children?
Okay. So again, excellent question. So thrifty gene again signifies that Barker hypothesis. So that means those children who are born low birth weight, which is like less than 2 kg or 1.5 kg, you're not supposed to overfeed them, because they have a genes which will help them to maintain their normal body structure despite the lack of nutrition. So what happens is the nature attempt that whenever you are born a IUGR or low birth weight, that you can fulfill, and because of the high insulin status, with the help of those 50 genes, you can maintain your certain body stature. But if you try to overfeed them, it can lead to overexposure and can lead to a metabolic syndrome and obesity. So the 50 gene or epigenetic does play a partial role in cases of SG or low birth weight children.
So you've almost gone to the next question, which was, does epigenetics play a major role in gene alterations and thus obesity?
Yes, it does.
So what you are saying is that a low birth weight child should be normally fed and we should not try to
Oh,
compensate the low birth weight by overfeeding and by
Overfeeding.
making him more.
Yes.
Yeah. Okay.
So what we
Uh,
tell them, we generally observe them on the growth chart, sir. Any increment of or any jump of 2 percentile line on growth chart is quite a significant. So we generally tell the parents to have a regular follow-up, and they should maintain their trajectory in those percentile lines. So if they are crossing 2 centile lines, that means if initially they are on third percentile and suddenly they are jumping on 25th or 50th percentile, I'm extremely worried. So this is how we generally tell them.
so even though they are within normal weight range, but that jump shows that they are going towards, they are sort of obese. They may
Yes.
have the problems related to obesity.
Yes.
Yeah.
Yes.
Okay. Wonderful. There is another question: how frequently leptin deficient obese child require injection leptin?
Once or twice a day subcutaneous injection, sir. And literature says that they have to be treated for good 3 to 4 years.
And after that, what happens?
After that, they're totally cured, sir. They
Okay.
complete
So
loss
it's not
of
a lifelong injectable.
no,
Yeah.
not really, not.
And you don't have a depot leptin where we can inject once a week or
Not
so.
at
No.
present. There is a metraleptin which is available, but it's very scarcely available. So at present, there's no depot preparation.
Okay. Priya, there is a question for you. How much protein per kilogram of body weight we can prescribe to the child who is on weight loss management diet?
okay. So I would first advise them to me. We have the recommended dietary allowance, which gives you with respect to age. And of course, that is for normal body weight. However, first take a dietary recall, see what is the current protein consumption. So we would look at least 15 to 20% of the calorie intake coming in from protein. Because it's very difficult if I want to just give 1 gram per kg body weight. So I use a little discretion anywhere between 0.8 to 1 gram. But of course, it's a little more calculated when it comes to at least 15 to 20% from the caloric intake, that much of protein. So if the child is eating about 1800 or 2000 calories, I would expect at least 20% of that calories coming in from protein.
Yeah. Yeah. So I think that you have already mentioned about 0.8 to 1 gram per kg.
Yes.
But yeah, okay. Okay, there is a question from Dr. Someshwar, approximate cost for surgery, sir, at Mumbai. So I think the cost of surgery varies between different hospitals. But important thing to realize is that from 1st October 2020, insurance is covering bariatric surgery. All the policies will be covering bariatric surgery. And that will be a game changer. Now the insurance companies can't refuse covering bariatric surgery, and they have defined packages. So their packages are somewhere around 2.5 lakh rupees, and most of the hospitals would be able to offer it around that price. So the bariatric surgery costs would be somewhere between 2.5 to 3 lakh to 3.5 lakh, depending on which surgery, which class of the hospital room you are taking, or which hospital you are going. But now this will be the price range in which bariatric will be offered across the country. Dr. Prashant, there is a question. Orlistat is banned, right? Orlistat is not banned.
Orlistat is not banned. It should not be used in a child in less than 12-year-old child. In fact, it is the only approved drug in childhood. That's the Orlistat, but it has to be used after 12 years.
And
metformin, we use it off-label.
Yeah.
In fact, it is not yet. Orlistat is not banned. We use it.
Okay, and in adolescent, it will be 60 milligram or 120 milligram?
We start with 60 milligram OD, sir, and
Yeah.
maximum we can give 120 milligram OD.
Yeah. Okay, there is another question. BMI not greater than 40, but apple-shaped fat distribution. Any surgical options for such distribution of fat? No, this is a major concern of patients. And they come, even if their BMI is 45, they say my fat is only in the central area. My face, you see, my face is so slim. My legs are slim. But it's all a relative thing, because abdominal area is where there are no bones. So this is the area which bulges out. Lungs can't bulge out because the rib cage, it doesn't allow it to bulge out. So, and also a good number of patients who or women who have delivered, they have lax abdomen, and that's why the bulge looks there. But obesity is everywhere. Obesity is not confined only to the central part, and there is no specific surgery for one particular part. Nobody takes out visceral fat surgically. So, if somebody has a certain fat on the back or on the hips, then a cosmetic surgeon can probably take out fat from there by a liposuction or lipectomy. But certainly, bariatric surgeon cannot help. And BMI is an important criteria to determine. Only in cases where there is uncontrolled diabetes, then BMI criteria is relaxed to 27.5 for treatment of diabetes. Otherwise, usually we go by 32.5 and 37.5 in India, or 99 percentile for children and adolescents. So I think, do you have any question, Dr. Prashant, for myself, or Priya? Do you have question for any of two of us before we close?
No, sir, I'm good.
So I think this has been a very informative session. Not only for those who are doctors and they advise to others, but doctors are also parents. So it's important that they be a role model for their own children, not only to prescribe to the patients who are coming. Every person who is a role model, their children will lose weight, and their neighbors' children will see, and neighbors will watch that doctor's family is healthy. So you are role model for many people, not only your children. And that is the way things can grow. That's the only way things can go. And I think childhood obesity is something that is in our hand to control. And if the child is also healthy, they will become as a responsible parent in future. So thank you very much, Dr. Prashant, Priya, for joining us. And thank you, Docplexus, for your support for this program. Thank you so much.
Thank you, sir.
Thank you, sir.
Thank you,
Thank
Dr.
you so much.
Prashant.